There's a sound that doesn't come from outside. You don't hear it when you're busy. You hear it when the room goes quiet, at night, in the early morning, or in the middle of a conversation when someone pauses, and suddenly it's there again, a ringing, a hum, a tone that has no source, and most people do exactly what they've always been told to do. They wait. They assume it's nothing. They tell themselves it's just a little tinnitus, just a bit of age, just something that happens when you've lived long enough and heard enough in your life. But here's what I want you to consider before we go any further. What if that sound isn't really coming from your ears? What if your ears are simply the last place this starts, and the brain is where it actually begins? Because that's exactly what the most recent research is pointing toward. And once you understand the mechanism behind it, that ringing stops sounding like a nuisance and starts sounding like something much more worth paying attention to. So if you've been living with that sound, or if someone you love has, stay with me. Because what I'm going to walk you through today may completely change the way you understand it. I'm Dr. Nora Khalil. I've been in clinical practice for over 12 years, and most of what I do is help people understand what their body is telling them, especially after 60, when the signals get quieter and the stakes get higher. If you're new here, this channel is a place where we take the things that often get dismissed or oversimplified, and we look at them carefully, with the respect they deserve. If this topic speaks to something you've noticed in yourself or someone close to you, I'd invite you to subscribe. That way you won't miss what we cover next. And if by the end of this you find it genuinely valuable, a like helps more people find this information. It's a simple thing, but it matters. Now, let's talk about what's really happening when your ears won't stop ringing. Most people think of tinnitus as an ear problem. And that makes intuitive sense. You hear the sound, so the issue must be in the hearing system, right? But here's where the understanding breaks down, and it breaks down in a way that explains why so many people try treatment after treatment and never quite get to the root of it. Your ears are actually quite passive instruments. They receive sound vibrations and convert them into electrical signals. That's their job. But those signals don't become anything you consciously hear until they travel through a pathway, a network of nerve fibers, and reach specific regions of your brain. The auditory cortex is where sound is actually processed, where it becomes meaningful, where it becomes real. The structure that carries that signal from the ear to the brain is the auditory nerve. And the broader pathway it feeds into is a complex network of neural circuits that interpret, filter, and give shape to everything you hear. Now think of this pathway as a wire, a long, delicate biological wire. When that wire is healthy, signals travel smoothly. Sound reaches the brain clearly. Interpretation is accurate. Silence is actually silence. But when that wire becomes damaged, when it becomes inflamed, when its protective coating degrades, when circulation to the nerve tissue becomes compromised, the signal distorts. It becomes noisy. It becomes unreliable. And the brain, which is always trying to make sense of incoming information, responds to that disrupted signal by generating sound of its own. That sound, in that ringing, that tone, that hum, isn't coming from your environment. It's your brain's response to a signal problem along the wire. That's the first thing to understand. This isn't just a hearing issue. It's a neural signal issue, and it has roots that go much deeper than most people ever look. Let me explain this wire in a little more detail, because understanding it changes everything about how you approach this problem. The auditory nerve is coated in a substance called myelin. You may have heard this word in the context of neurological diseases, and that's actually relevant here, though for a different reason. Myelin is a fatty, protective sheath that wraps around nerve fibers the way insulation wraps around an electrical wire. Its purpose is to allow signals to travel quickly and cleanly. When myelin is intact, the signal moves efficiently. When myelin degrades, the signal becomes slow, scattered, and unreliable. After 60, myelin breakdown accelerates in many people, not always dramatically. Not always, obviously, but at a cellular level, the insulation on these neural pathways begins to thin, and the auditory nerve is one of the structures where this can have very noticeable consequences. What causes myelin degradation? Several things. Chronic inflammation is one of the most significant. Nutritional deficiencies, particularly B12, magnesium, and certain fatty acids, are another. Poor circulation, which becomes increasingly common with age, means the nerve tissue receives less of the oxygen and nutrients it needs to maintain its structure. Here's what this means in practical terms. When the myelin thins around the auditory nerve fibers, some signals still travel cleanly, others don't. The result is a kind of electrical interference, a continuous background noise that the brain picks up and interprets as sound. That's the ringing. And it's not a symptom that lives in your ear. It's a symptom that lives in the nervous system, in the wire, in the state of that wire's insulation, its nourishment, its integrity. This is why some people notice that their tinnitus gets louder when they're exhausted, or during periods of high stress, or after they've been sick. All of those states affect the nervous system directly. All of them affect the quality of signal transmission. Now I want to talk about why this becomes more relevant after 60 specifically. Because this isn't just about getting older in a vague sense. There are specific documented changes that happen in the auditory system during this period of life, and understanding them helps you see why a problem that used to be small can start to compound quietly. First, the hair cells inside the cochlea, the inner ear, begin to decrease in number over time. These cells are responsible for converting sound vibrations into electrical signals. Unlike most cells in the body, cochlear hair cells do not regenerate. Once they're gone, they're gone. Now, the loss of some hair cells over a lifetime is considered a normal part of aging. The clinical name for this is presbycusis. But what's less commonly explained is that even before significant hair cell loss, a reduction in the density or function of these cells changes the quality of the signal being sent to the auditory nerve. Think of it this way. If 100 clear voices are sending a message, and over time only 70 are speaking, and some of them are speaking quietly or at the wrong pitch, the message that arrives at the destination is less coherent. The brain receives a degraded version of what the ear is picking up. In response, the brain compensates. It increases its own sensitivity. It essentially turns up its internal volume, trying to make up for the weaker input. And here is where the problem compounds. A brain that is trying to amplify a degraded signal is also amplifying any distortion in that signal. The result, in many cases, is tinnitus. This is why tinnitus becomes significantly more common after 60. It's not simply that the ears are worse. It's that the relationship between the ear and the brain shifts in a specific way, and the brain's response to that shift is to generate noise. And here's the part that most people never connect. This same mechanism, the brain's increased sensitivity to disrupted input, is also related to why some people with tinnitus begin to have trouble concentrating, or notice that their sleep becomes fragmented, or feel that their overall cognitive sharpness has changed. These are not separate problems. They are expressions of the same underlying tension in the auditory neural system. I want to talk about something that's very common, and that often makes this condition significantly worse without anyone realizing it. Many people, when they develop tinnitus, instinctively try to mask it. They keep the television on. They sleep with a fan running. They fill the room with background noise so they don't have to hear the ringing. And I understand this completely. The sound is disruptive. It interferes with sleep, with focus, with the ability to be present in a conversation. Looking for relief from it is natural, but here is where the strategy becomes counterproductive in a very specific way. When you consistently mask the tinnitus with external sound, you're not resolving the underlying signal problem. The brain's attempt to compensate for the disrupted auditory input continues. And over time, the brain can become more deeply entrenched in the pattern of generating that internal sound, because the pattern of compensation itself becomes reinforced. There's something in neuroscience called neuroplasticity. It's the brain's ability to change and adapt based on experience and input. Most of the time, neuroplasticity is a hopeful concept. It means the brain can learn, recover, and rebuild. But neuroplasticity works in both directions. The brain also strengthens patterns that are repeated. If the auditory brain circuits are consistently engaged in compensatory sound generation, those circuits can become more established, not less. This doesn't mean you should never use masking sounds for comfort. There is a place for them, and they can genuinely help with sleep and anxiety. But it does mean that masking alone, without addressing what's happening in the wire, in the nerve pathway, in the underlying neural signal, is not a solution. It's a temporary relief that leaves the root problem untouched. What the research is pointing toward is that the most meaningful interventions are the ones that address the health of the auditory nerve and the brain circuits it feeds. Nourishment, circulation, reducing inflammation, protecting the myelin, giving the system what it needs to transmit signal clearly, rather than simply covering the distortion with noise. There's a concept in auditory neuroscience called central gain, and it explains something that almost nobody ever mentions to people living with tinnitus. When the input coming from the ear decreases, whether due to hair cell loss, nerve degradation, or simple age-related hearing changes, the brain doesn't just accept the quieter signal passively. It actively increases its own amplification. It turns up the gain on its auditory processing circuits. Think of a microphone and an amplifier. If the microphone becomes less sensitive, you turn up the amplifier to compensate. The sound gets louder, but so does every artifact, every bit of static, every imperfection in the line. That's what the brain does. And the static, the imperfections in the auditory signal, become the ringing. But here's what this tells us that goes beyond the tinnitus itself. Central gain is a neurological process. It lives in the brain's auditory cortex, and it interacts with other systems, including the limbic system, which governs emotional response, and the prefrontal cortex, which governs attention and focus. This is why tinnitus is so often accompanied by anxiety. Not because the person is emotionally fragile, but because the neural circuits involved in auditory processing are in direct communication with the circuits that regulate emotional state. When those auditory circuits are in a state of heightened sensitivity and chronic noise generation, the emotional circuits don't remain unaffected. This is a physiological relationship, not a psychological weakness. And recognizing it as such changes how you approach it and how much compassion you extend to yourself or someone you love who is struggling with it. The brain is not malfunctioning arbitrarily. It is responding logically to a signal problem. The question is whether we can address the signal problem at its source, in the wire, in the nerve, in the conditions that allow or prevent healthy transmission. Before I continue, and because this next section is directly about what can actually be done, I want to mention something that I think is worth looking into. There's a specific mechanism that's been getting attention in research around auditory nerve health and tinnitus. It involves the way certain natural compounds interact with the neural circuits we've been discussing, not masking the sound, but actually supporting the biological conditions the auditory system needs to function more cleanly. I've looked at a presentation that walks through this in detail, a documented mechanism that connects brain circuit malfunction to tinnitus and identifies a natural approach that targets it specifically. It's one of the clearer explanations of this that I've seen, and it aligns with what the current science is showing about the wire, the gain, and what the nerve actually needs. If you're curious about that, the link is in the description below and in the first pinned comment. It's worth a few minutes of your attention, especially after what we're about to get into next. Here's a factor that comes up repeatedly in the research and almost never comes up in a regular doctor's appointment when someone reports tinnitus, chronic, low-grade inflammation. Not the kind of inflammation you can see or feel, not swollen joints or a fever. The kind that circulates quietly through the body over years, affecting blood vessels, nerve tissue, and cellular function without producing obvious symptoms. After 60, chronic inflammation is extremely common. It's been linked to cardiovascular disease, cognitive decline, metabolic issues, and joint deterioration. But its effect on the auditory system is less often discussed. The auditory nerve, like all neural tissue, is dependent on a clean, unobstructed blood supply. The tiny blood vessels that feed the cochlea and the auditory nerve are among the most delicate in the body, and they are highly vulnerable to the effects of inflammation and vascular dysfunction. When these vessels are compromised, when inflammation thickens the blood, narrows the vessels, or disrupts the microcirculation in the inner ear, the nerve tissue begins to receive less oxygen and fewer nutrients than it needs. The myelin thins, the signal degrades, the brain increases its compensatory gain, and the ringing begins or intensifies. This is the pathway that connects inflammation to tinnitus, and it's also the pathway that connects cardiovascular health to hearing health, two areas most people never think of together. High blood pressure is one of the most consistent risk factors associated with tinnitus. So is diabetes. So is a sedentary lifestyle. Not because these are ear diseases, but because they all impair the microvascular environment that the auditory nerve depends on. This is an important reframe. If you have tinnitus and you also have unmanaged blood pressure or blood sugar, the ringing in your ears may partly be a reflection of what's happening in your vessels, and the path toward improvement runs directly through those systems. Let's talk about something practical and often overlooked: what the auditory nerve actually requires to stay healthy and what happens when those requirements aren't met. Magnesium is one of the most important minerals for auditory nerve function and one of the most commonly deficient in adults over 60. Its role in the nervous system is fundamental. It acts as a natural buffer for the nerve cells, helping to prevent overstimulation. When magnesium levels fall, nerve cells become hyperexcitable. In the auditory system, this contributes directly to the kind of erratic signal generation that produces tinnitus. Vitamin B12 is another critical factor. B12 is essential for the production and maintenance of myelin, the protective coating around nerve fibers we discussed earlier. B12 deficiency is strikingly common in older adults, partly because the ability to absorb it from food decreases with age, and partly because many common medications interfere with its absorption. Without adequate B12, myelin degrades faster. The wire loses its insulation. Auditory signal quality declines. Zinc plays a role as well. The cochlea contains one of the highest concentrations of zinc of any tissue in the body. Zinc is involved in the activity of specific enzymes that protect the inner ear cells from oxidative damage. Deficiency in zinc has been associated with an increased risk of tinnitus, particularly in older adults, and some clinical studies have shown improvement with supplementation in zinc-deficient individuals. Omega-3 fatty acids, the long-chain form found in certain foods and supplements, are essential for maintaining the flexibility and function of nerve cell membranes. A diet that is chronically low in these compounds contributes to a less resilient neural environment throughout the auditory system. None of these are exotic. None of them require a prescription. But they do require attention, especially after 60, when the ability to absorb, convert, and retain many of these nutrients naturally decreases. The body doesn't become deficient because something is catastrophically wrong. It becomes deficient because the machinery of absorption and utilization quietly changes with age. An intake that was sufficient at 40 may no longer be sufficient at 65. There's a connection that I find particularly important to address because it tends to close a loop that many people haven't seen clearly before. Tinnitus disrupts sleep. This is well established. The ringing is louder in the absence of other sound, and silence, which is supposed to be restorative, becomes an amplified chamber for a sound the nervous system can't shut off. But here's the direction the relationship also runs. Poor sleep makes tinnitus worse. Sleep is the period when the brain consolidates the day's learning and repairs cellular damage, including in neural tissue. During deep sleep, the glymphatic system becomes active. This is a recently discovered network through which the brain clears metabolic waste products. Cerebrospinal fluid flows through the brain's tissue, washing out byproducts that accumulate during waking hours. Among the substances cleared during this process are inflammatory compounds that, when allowed to build up, contribute to neural inflammation, including the kind that affects auditory nerve function. When sleep is chronically fragmented or shortened, this clearance process is incomplete. Inflammatory burden in the brain increases. Nerve tissue operates in a less healthy environment, and the tinnitus, driven in part by neural inflammation and disrupted signaling, becomes louder and more persistent. This is a cycle that feeds itself. tinnitus disrupts sleep. Poor sleep increases neural inflammation. Neural inflammation worsens tinnitus, and so the ringing becomes a fixture, not because it is irreversible, but because the cycle maintaining it is never interrupted. Recognizing this cycle is important because it means that improving sleep quality is not just about comfort. It's a direct intervention in the biological environment that tinnitus depends on to persist. Prioritizing sleep, protecting its depth and duration, addressing what fragments it, is one of the most underappreciated strategies in managing what happens in the auditory brain circuits. And after 60, when sleep architecture naturally changes and deep sleep becomes shorter, this deserves more attention than most people give it. I want to close the scientific picture with something that I think represents a genuine shift in how this condition is being understood, because it changes what seems possible. For a long time, tinnitus was considered largely irreversible. The dominant view was hair cells are lost, damage is done, the ringing is a permanent feature of the landscape, learn to live with it. That view is being revised, not because tinnitus is easy to treat, it isn't, not because there's a single solution that works for everyone, there isn't, but because the understanding of where tinnitus lives has changed. And when you locate the problem more precisely, the possibilities shift. If tinnitus were purely a matter of missing hair cells, then yes, reversal would be essentially impossible because those cells don't regenerate. But if tinnitus is significantly a matter of how the brain's auditory circuits are responding to degraded input, if it's a matter of neural inflammation, myelin integrity, central gain, circulatory health, and nutritional environment, then many of those factors are, to varying degrees, addressable. The brain's auditory circuits are plastic, they can reorganize. The inflammatory burden in the nerve tissue can be reduced. The nutritional deficiencies that compromise myelin and nerve function can be corrected. The microvascular environment that feeds the cochlea and the auditory nerve can be supported. None of this is a guarantee of silence, but it is a basis for action, real physiologically grounded action, rather than passive acceptance. And that distinction matters, not just medically, it matters for what kind of relationship you have with your own body, whether you see the ringing as a sentence or as a signal worth responding to intelligently. I want to leave you with something that I hope changes the way you think about this from now on. When you hear that ringing, when it shows up in a quiet room or interrupts a moment of rest, I'd encourage you to stop thinking of it as noise and start thinking of it as information. Your auditory system is a biological structure. It has requirements, nutritional, circulatory, neurological. When those requirements are met, it functions with clarity. When they aren't, it begins to send imperfect signals, and the brain, doing exactly what it's designed to do, tries to make sense of those imperfect signals and produces sound in the process. That sound is telling you something about the state of a wire, about how well that wire is being nourished, insulated, and supplied with blood and oxygen, about the inflammatory environment surrounding it, about what the brain is trying to compensate for. The people who do best with this, who find the most meaningful improvement, are not the ones who simply wait or mask or accept. They're the ones who take the signal seriously and respond to what the body is actually asking for. After 60, your body communicates differently than it did at 40. The signals are often quieter, subtler, easier to dismiss, but they are not less important. If anything, they are more important, because the margin between early response and late consequence narrows with time. You are not obligated to interpret that ringing as just the sound of getting older. You are allowed to ask what it's telling you. You are allowed to look deeper. And now you have a more complete picture of where to look. Pay attention to the wire, nourish it, protect it, give it what it needs to carry sound cleanly from your ears to your brain, and to carry it the way it was meant to be carried. That's where this begins, and that's where the possibility of real improvement lives.